Okay, so the lumen, as you see here, is going to be very narrow. So because of the hypertrophy of the tunica media. Okay, so let's keep going. So signs, symptoms of hypertension. So mostly of the signs and symptoms of hypertension are going to be very few if there is no existence of any signs and symptoms. But some people are going to have only just a headache, and this headache mostly is located in the occipital area of the head. Signs, we have the fundoscopy. The fundoscopy is going to check the papilledema. Papilledema, what it is the swelling of the optic nerve where the optic nerve enters into the eyeball. So this is very common to see in fundoscopy in persons who want to know what is the progression of the disease. Especially there will be some bleeding on the retina producing blindness. So here we have the treatment that we are going to talk about hypertension. We have A, B, C, and D. ACE inhibitors, ARBs, angiotensin receptor blocker, alpha-1, beta blockers, calcium and diuretics, vasodilator. We are going to talk about the renin, the ARA, that is the aldosterone receptor antagonist, and alpha-2. So if you see here, we are going to talk in the three topics, hypertension, angina, and heart failure, about 15 medications. And hypertension, we have 10. The rest we are going to talk about in the next hour. All right, so here we have all the medications. We have 15 medications, and everything that is in yellow is the ones who are being used mostly for hypertension. They can be used for angina or heart failure, for example. And let's start with this graphic. In this graphic here we have 5 of these medications who are going to treat hypertension. I'm very brief. Here we have the kidney, we have the liver, we have the lungs, we have the adrenal gland, and they go back to the kidney. So what happened here is the liver is going to produce the angiotensinogen, and kidney is producing renin, and the renin activate transform the angiotensinogen into angiotensin 1. This angiotensin 1 go to the lungs. In the lungs, it's going to be activated by the ACE, it's a angiotensin converting enzyme, and transforming angiotensin 2. Angiotensin 2 go to the adrenal gland, and the adrenal gland produce the release of aldosterone, who produce the absorption of water and sodium. So that is how they are going to increase the blood pressure. So if we have high blood pressure, we are going to have, for example, the renin blocker. Renin blocker that is going to block the release of the renin, inhibiting the angiotensinogen to transforming angiotensin 1. At the end, there is no aldosterone. There are going to be less volume. The cardiac output is going to diminish. Now, in addition to that, this angiotensin, they have a name for reason, because these substances can produce the vasoconstriction of the peripheral vessels. So, in conclusion here, the renin is going to be inhibited by this renin inhibitor, and renin inhibitor produce this blockage of the cascade. At the end, there is no production of aldosterone, and there is unpromote the vasodilation. Why? Because angiotensin produce vasoconstriction. That's why it's called angiotensin. Angio, tensin, pressure. And blocking this from the beginning, there is no vasoconstriction, means promote the vasodilation. In addition to that, they are going to prevent the absorption of water and sodium. All right, so let's keep going. We have the ACE inhibitors. So the ACE inhibitors is the other enzyme that is going to inhibit actually the transformation of angiotensin 1 into angiotensin 2. So this is the second hormone. The third hormone is going, the third medication, sorry, is ARBs, okay, is angiotensin receptor blockers. Angiotensin receptor blockers is going to block the angiotensin 2 that goes to the adrenal gland, so they never reach because it's blocked. And this step is going to block the aldosterone production, making the cardiac output going down. We have two more. The next one is going to be ARA. ARA is the aldosterone receptor antagonist. ARA is a medication who is going to block the receptors of aldosterone in the kidney, making the kidney not able to reabsorb sodium and water. So we have four of them, and at the end we have the thiazides that is going to inhibit the absorption at the level of the distal convolute tubule. So if you see all these mechanisms we call RAS, is the renin-angiotensin aldosterone axis. So the renin is blocked, the ACE, the enzyme that transform angiotensin 1 and angiotensin 2 are blocked. We are blocking the receptors for the aldosterone. We have for the angiotensin receptor blocker. We have the blockage of the aldosterone receptor antagonist and the thiazide. So we have 5 of these medications. One thing we need to remember is the blood pressure is related directly to the cardiac output and peripheral resistance. The cardiac output, so everything that is going to increase volume is going to increase cardiac output, increase the blood pressure, and the opposite. Volume go down, cardiac output go down, blood pressure go down. Heart rate. Heart rate is going to be, for example, volume, for example, thiazides is going to inhibit the decrease the volume in the blood, so cardiac output go down. Heart rate, propranolol, for example. Vasodilators, that peripheral resistance depends on the vasodilation and vasoconstriction. So the more vasodilation, the less peripheral resistance. The more vasoconstriction you have, the less vasoconstriction you have, less peripheral resistance. So vasodilation, for example, we have alpha-2 agonist, and vasoconstriction, this is going to be blocked. The vasoconstriction is going to be blocked by the alpha-1 blockers. All right, so let's start with the ACE inhibitors. ACE inhibitors, we have the suffix pril. We have the super favorite for NCLEX is going to be the captopril. Captopril or capoten, captopril, pril. And mostly all these medications, we have the benzanapril, enalapril, etc. And these medications, they have the characteristics, mostly all of them, that they need to be metabolized by the liver. But one exemption, and that's what in English they like to ask, captopril. Captopril is not a prodrug. Prodrug means that a drug needs to pass through the liver. So the liver receives the prodrug, and the liver is a factory, metabolize this drug and produce the active drug at the end. So the captopril doesn't need that. So mostly the rest of the ACE inhibitors, yes. So conclusion about nursing considerations is the patient is having liver failure or liver dysfunction, it's okay to give captopril because they are not going to pass through the liver to be metabolized. Okay, so what is doing the ACE inhibitor? We saw in the previous slide that block the angiotensin 1 to angiotensin 2. All right, so let's go directly to the topic. So ACE inhibitors, mostly A's, everything that starts with A or B, mostly they are not going to be effective in African American. It's just a coincidence. So lucky us to remember that ACE inhibitors, ARBs, for example, ARAs, are not going to be effective in African American population. Okay. All right. So here we have the ACE inhibitor protect the kidney because lower glomerular pressure, glomerular filtration pressure Therefore, it's preferred an hypertension, diabetes mellitus patient. So ACE inhibitors, one of the things, diabetic patients, they have hypertension, right? Because the narrowing of the vessels in the diabetic patient. So that is going to decrease the blood supply to the kidney. So the ACE inhibitors in this case is going to help to work with less effort the kidney giving ACE inhibitors because they are going to lower the glomerular filtration or pressure of the kidneys. All right, so adverse effects. So we have in general all antihypertensive are going to be having orthostatic hypotension. Very important here is that these medications need to be held and if the blood pressure is going to be lower than 100 millimeters of mercury. So we have the ACE inhibitors. We have another recommendation for holding medication according to some indications like in propranolol, like in digitals, digoxin, that we are going to see now. At this moment, remember ACE inhibitors. They need to hold the medication and call the prescriber if systolic pressure is less than 100 millimeters of mercury. All right, so here we have the ACE inhibitor. We have, please remember this mnemonic, ACE, angioedema. Angioedema, this is angioedema, swallowing of the face, tongue, cheeks, eyes, etc. Cough, chronic cough. We are going to explain how coughing another time. Very interesting. Electrolyte imbalance. And electrolyte imbalance, please remember, we have hyperkalemia, 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 hyperkalemia. Nephrotoxicity, but here we was talking about protecting the kidney. So protecting the kidney is going to be in patients with diabetes mellitus or in general, but here it's going to become nephrotoxic only if the kidney is having renal artery stenosis. When renal artery stenosis, these ACE inhibitors are going to be contraindicated. One thing I want to here, we have the initial first dose effect is very important for NCLEX. First dose effect, initial dose may cause hypotension. And another thing is that NSAIDs are going to diminish the effect of the ACE inhibitors. Okay, NSAIDs. So be careful with the NSAIDs because the ACE inhibitors lose the effectiveness. All right, so that is about ACE inhibitors. Let's go to the ARBs. That is the angiotensin 2 receptor blocker. Angiotensin receptor blocker, you know, is angiotensin, very important, is vasoconstrictor. So it's going to block the angiotensin 2, so promote the vasodilation. Okay, so block the vasoconstriction means promote the vasodilation. Is going in addition to bind the angiotensin 2 receptors, so they're going to stop their angiotensin 2. They are not going to go to they're not going to make or find a receptor that is found in the adrenal gland. In the adrenal gland, they have receptor for angiotensin 2, and these receptors are going to be blocked. So the step from this is that the adrenal gland cannot produce aldosterone. So the suffix is sartan or mesartan. Here's A again. African American may not respond well by this therapy. What we need to remember that many of the A's, and that is another coincidence, they are going to produce, for example, headaches. And how we are going to handle headaches, for example, we already talked about ACE inhibitors, ARBs, and headaches mostly is controlled by what? By Tylenol, acetaminophen. Remember sartan or mesartan. Important to remember about ARB, African American non-responsive, and common side effects, headaches, that nursing consideration is just to prevent with some acetaminophen. We have alpha-1 blockers, another A. We have 3 A's so far. Alpha-1, what is doing? Alpha-1 normally doing vasoconstriction. So if we give alpha-1 blocker, promote the vasodilation, and the vasodilation are going to decrease the peripheral resistance. So what we need to remember here is, again, so remember we was talking about the first dose in the ACE inhibitors. We are going to have the same problem here with the alpha-1 blocker, prazosin. Prazosin is the mini press, doxazocin. So please pay attention to this. Doxazocin are going to be alpha-1 first dose hypotension. First dose hypotension. Another A, we have headache. So everybody's headache so far, right? So you know how to handle the headache at this moment. So we have the first dose is related to the ACE inhibitors and for the alpha-1 block. Okay, so we have the next is AB. We already talked about ACE, ARBs, alpha-1 blocker, and now is the turn for beta blocker. There is few things that we need to remember. First of all, the suffix is LOL, LOL, is propanolol, atenolol, and I put there is many more of these, but actually I put the prototypes here. Propanolol is no selective. Atenolol is a selective beta-1 blocker. It's beta-1 blocker. It is beta-1 blocker. Propanolol is no selective, and atenolol is selective. So what does it mean? That means that a beta blocker, for example, when you give propanolol, that is much more common to use propanolol, they are going to have effect in beta 1, but when you increase the dose, they're going to have in beta 2. So what is doing beta 1 blocker? Is going to block beta 1, right? Beta 1, what is doing normally? Normally, physiologically, beta 1 produce increase the heart rate and increase contractility. So beta blockers, what they are going to do is the opposite. They produce the diminish of the heart rate, diminish the heart rate, and diminish the contractility. So diminishing just the heart rate, they produce a diminishing of the cardiac output, right? Cardiac output, you know, is volume by heart rate. The heart rate go down, cardiac output go down, and the blood pressure go down. So now beta 1 is beta 1 is blocked. So now this propanolol is non selective, so they can block beta 2 too. So beta 2. So what is normally doing beta 2? Beta 2 is bronchodilation. But if you give beta 1 blocker that is not selective, affecting the beta 2, blocking beta 2 produce bronchoconstriction. So you never give it to a patient who has asthma, because that can produce bronchospasm. How you can check bronchospasm with wheezing? The wheezing is the narrowing of the tubes of the bronchi, so that produces sound as a whistling, right? Again, we have A and Bs. The A and Bs are not effective for African American population. So we have hold medication. We are going to hold medication, as you already know, in ACE inhibitors and beta blocker and digitals that are very important to remember. In this case, beta blockers hold the medication if the blood pressure is less than 100 millimeters of mercury, similar as the ACE inhibitors. And here, the beta blocker, because diminish the heart rate, you can hold the medication if the heart rate is less than 60 beats per minute. Okay. Another one is that the NSAIDs can inhibit the effectiveness. NSAIDs can decrease the effectiveness. Okay. So so here we have ACE inhibitors. The NSAIDs can decrease the effectiveness of the ACE inhibitors, and the beta blocker can the NSAIDs can do the same, may inhibit the effectiveness. So there's a very common things between these two group of medications. So here we have the summary. Here we have the first dose. We have the prazosin and doxazocin. So for NCLEX, SOSIN is alpha 1 blocker. Don't care about the commercial name, just a generic name is more important. And we have first dose, we have the alpha 1 and the ACE inhibitor. So this is a summary of what we just previously said. And the NSAIDs decrease effectiveness of the ACE inhibitors and the beta 1 blockers. So hold indications, we have ACE inhibitors, beta blocker, and digoxin. So those are, we already talked about ACE inhibitor when the blood pressure is less than 100 millimeters of mercury, and the beta blocker when the blood pressure systolic is less than 100 millimeters of mercury and or the heart rate is less than 60 beats per minute. Digoxin is coming. All right, so let's keep going here. We have calcium channels, the hyperkalemia, we are going to make a summary at the end. We have A, B, C. We have, again, let's do it, ACE inhibitors. We have ARBs. We have alphas, all A. Then is B, beta blocker. And then we are going to start with the channel, calcium channel blockers is C. C, we have the suffix pin, nifedipine, amlodipine, felodipine, VLTSM, well, it's not the rule here, verapamil. So all these guys are going to be the calcium channel blockers. What is doing the channel calcium blockers? Very simple, the entry of calcium into the cell. You know, for a muscle contraction of the myocardium, you need the entry, first of all, of sodium, and then the entry of calcium to complete the contraction. So in this case, there is no that amount of calcium that that supply to the whole fibers of the myocardium. So not all cells are going to contract because they don't have enough calcium. And that's why is going to, the contractility is going to diminish. So that means the peripheral resistance go down and the blood pressure go down. All right, so calcium. So A and B are not effective for African American patients, but C and D, yes, what is coming? Calcium channel is effective for African American population. Calcium channel blockers. We have calcium channel blockers produce main side effect is constipation. Constipation, why? Because calcium do not enter neither in the intestinal cells that need for the contraction of the muscle of the intestine. So that can produce constipation. The stools stay longer, reabsorption of water happen, and getting dry, and constipation occur. All right, diuretics, we have the thiazides. So that is the first line. So you remember that in the pre-hypertension is just diet and habits. And hypertension type 1 is you start with thiazides, and hypertension grade 2, you're going to continue with adding medication, thiazides, and for example, you can add another medication like ACE inhibitors or propanolol or ARBs. Okay. Oh, one thing I want to mention before passing this is about the ACE inhibitors. The ACE inhibitors, you have, remember we was talking about the mnemonic. Yeah, so cough is all going to pass happening in only 30% of the patients. It's dry cough. What we do is just to change medication. So you pass from ACE inhibitors to ARBs. And ARBs do not have that problem. So you can pass from ACE and ARBs if the case of the patient is coughing. All right, so we have ARA. ARA, again, this is a aldosterone receptor antagonist. What do you need? Oh, I just jumped once. Well, let's go back here. So aldosterone receptor antagonist is the eplerenone. Eplerenone, you must be familiar with this name. Aldosterone receptor antagonist. What is doing this is that block the receptor for the aldosterone where in the adrenal gland. So the adrenal gland do not produce the aldosterone. We have the direct renin inhibitor. So remember, all these drugs are going to be used for hypertension. It's blocking the renin. Remember the first graphic we did our renin-angiotensin aldosterone axis. And renin inhibitor is aliskiren. So kind of suggestive name for direct renin inhibitor. So you must be familiar with that. So what we need to remember here is the A, B, and the renin inhibitors are not effective in African American population. All right, and this kind of new medication, first of all, we are going to use the most common, the ACE inhibitors. We are going to use the propanolol. We are going to use diuretics, and then we are going to use, for example, ARBs. You're going to use the direct renin inhibitors, the liskirin, or then at the end, the eplerenone. So these new medications mostly tend to be used if the previous medications are not making effect. So we have direct vasodilators. They are not being used so commonly because they have another better activity in other situations. Because it's not last longer the effect in the patient with hypertension. So mostly it should be given for emergency situations or crisis or some emergency situations of high blood pressure. Hydralazine is a prototype, and this is mostly used for decrease or relax the BPH, the benign prostatic hypertrophy, hyperplasia or hypertrophy. So, but produce a very potent vasodilation. It's not that common to use this. We have the alpha-2 agonists. We have the clonidine and catapres. This is very important. Catapres or clonidine, the methyl dopa, is going to have the rebound effect. If you give the medication and you suspend or stop the medication suddenly, you're going to have the hypertension and tachycardia rebound effect. So that is something that we don't want to happen. So here we have the hypertension treatment in African American, not effective ACE inhibitors, not effective ARB, not effective beta blockers. So there we have our A's and B's, and not effective the renin inhibitor in African American. Effective the ACE inhibitors only if you add diuretics. Okay, and effective for African American is the calcium channel blockers. Headache. This is very easy to remember. All the A's, practically, all the A's, ACE, ARBs, alpha, one blocker, renin, and the fatty oxy inhibitor, nitrate, that we are going to see this is for angina, and this is for angina too. They are going to produce headache. So we are going to see that in the next slide. Let's talk about angina. And talking about angina, we will talk about two main medications, the nitrates and the fatty oxidase enzyme inhibitor. So let's not be afraid about this fatty oxidase enzyme inhibitor because it's easy to remember, and we are going to explain in very simple way. So we have angina. Angina, you have the definitions of chest pain. We have a stable angina and a stable angina or variant angina or the Prince-Metal, called the Prince-Metal angina. Stable. Stable means if you're in rest, you don't have pain. If you do exercises or some exertion, you have pain on the chest. And stable means that doesn't matter if you're resting or you are exercising, it's going to give you chest pain. And the variant angina is Prince-Metal, is a vasospasm. It's a spasm of the vessels that are going to be temporary, but they can be treated right away with some, for example, ACE inhibitors. All right, so we have a stable angina. Stable angina is mostly the medications that we are going to see now. Unstable angina, mostly what they do is a surgical procedure, mostly bypasses. And variant is actually medical treatment too. All right, so let's keep going. So here we have the ACE inhibitors, the beta-adrenergic blocking agents, calcium channel blockers, similar to hypertension, right? Fatty acid oxidase inhibitors, nitrates, statin. Oh, this is very important because this is included in the protocol for um, treatment of angina. We have statins have become a standard in drug therapy. Why is this? So what is doing? Is antihypertensive? Is a vasodilator? Of course not. A statin is a HMCO reductase inhibitor that is going to decrease the levels of cholesterol, right? And that is what is actually prevent to not make a progressive deposit of cholesterol and narrow even more the coronary arteries that is the cause of the angina. All right, so nitrates. Nitrates, we have the nitroglycerin. Nitroglycerin decrease oxygen demand. So that is going to decrease the preload. What is the preload? Is the venous return. So all the blood that is coming from the IVC are going to drain into the right atrium. So that volume is going to decrease and decrease the afterload. What is afterload? Afterload is not volume. Afterload is how strong or how the strength of the ventricle to contract. So that is the afterload. Afterload. Okay. All right. So another here is one of the recommendations that you need to tell to the patient is that they need to carry the medication with him or with her at all the time. So you take the medication. If you have some angina or chest pain, you're going to take some medication, nitroglycerin here, sublingual, for example, and wait about 5 minutes if that is going to pass. If not, take another pill and you need to call 911 at that time. You can repeat after another dose after 5 minutes. All right, so what is important here is headache. Headache, everything that we was looking about headache, if you know the side effect, you can prevent this headache. First of all, this nitroglycerin, with the time, the headache is going to diminish and is going to be, it's not going to show anymore. But you can try, you can give the patient Tylenol in order to control that pain previous to take the medication. All right, so drug interaction, the sildenafil, that is a Viagra, potent vasodilator, can, when they give it together, can produce orthostatic hypotension, can produce deprivation of the blood supply to the brain and coma and death. Okay, so let's keep going. So so here we have another thing that is important to is about the tolerance. The tolerance of the nitrates are very common, and tolerance you need the same more dose to have the same effect as previous days. So in order to prevent that, you need to give the patches, mostly the transdermal disc, during the night. Why at night? Because they is unrest, right? The patient is not in activity. The heart do not need that overload of working. So that's why it's better to give it during the day and take it out during the night. I need to correct me myself. I said I said the opposite. So the transdermal disc should be given during the day. Why? Because this is the time where the heart is acting more actively, right? So that's why the demand of oxygen is increased. So the nitroglycerin, what is going to is decrease the preload and the afterload. So that is how we do in the morning. And then at night, we are going to remove it. because the patient is in rest. That's the heart is not working as much as in the morning. So we need to remove about 8 to 12 hours. And this medication is this in order to prevent the tolerance. Inform the patient of medication deterioration every 6 months. Nitroglycerin prescription should be refilled, and dark colored glass container should be used for storage. So this the medication should be stored under jars that are dark. Otherwise, the light is going to inactivate that the medication. All right, so this nitrate cannot be mixed with other medications. Use a special nitro tubing because the nitroglycerin can be attached to the walls of the normal tubing. So that is going to decrease the amount of nitroglycerin given to the patient. That is going to decrease, the effects of the anticoagulants. All right, so we are talking about angina, correct? And the next one we talk about is the fatty oxidase enzyme inhibitor. And that is a name that we must remember is the ranolazine, Ranexa. What is Ranexa doing? Ranexa what is doing is that the cells of the myocardium, they are not going to use, in other words, they are going to prevent the use of fats for energy. Instead of that, we are going to use glucose. That is easier, and they need less energy, less ATPs in order to create energy. So the glucose, in this case, the glucose are going to be easier to metabolize with less use of energy. So that means less demand of energy from the heart. So that's why this fatty oxidase enzyme inhibitor inhibit the metabolism of the fat in the myocardial cells and stimulate the glucose being used through glycolysis and Krebs cycle. All right, so these are going to be used for stable angina, all these medications. Remember that unstable angina, you need to mostly program a bypass or surgery. All right, so dizziness is one of the most common side effects. In liver dysfunction is contraindicated, so no liver dysfunction you need to have a healthy liver in order to be able to take this medication without any problem. So let's talk about heart failure, and here we are going to talk about 3 medications. We are going to have the phosphodiesterase inhibitors here in the bottom. Here we have the natriuretic peptide, and we have the digoxin. So heart failure. So in classroom, we were talking about what is the pathophysiology of the heart failure in order to understand what is doing this medication. In conclusion, the heart failure we have is that the heart is not pumping properly. So we need medication who is going to make stronger the contractility of the muscle. In this case, we are going to decrease the preload, decrease the afterload. Of course, you're going to decrease the sodium diet, and they are going to decrease the contractility. So contractility diminishes is mostly related to the afterload. Okay, so signs and symptoms, cough. Why cough? Because the heart cannot pump all the blood, so there is some flooding of fluid of blood into the lungs. So this increased pressure of the pulmonary arteries within the lungs is going to make escape water and produce flooding. So that is what is giving the coughing. Okay, so the same thing with dyspnea on exertion. So there is less area of the lungs, of the alveoli, because they are flooded and the exchange of gases are diminished. Dependent edema, so that means that the patient, when he's sitting down or standing up, they are going to, by gravity, the fluid go to the lower extremities, so dependent edema. So these guys, they need to be with the elevation of the legs. One of the signs of history that you are going to tell is that sleep with extra pillows. Extra pillows. Why they need to to have extra pillows? Because doing kind of semi-folded position, they have um, more support to the diaphragm in order to for ventilation. Remember that in heart failure, the patient's having some flooding of fluid in the lungs. Pulmonary edema, and S3 and S4, that is another topic. So we have assessment, 6 cardinal signs of heart disease. Breath, short of breathing, coughing, wheezing, dizziness, edema, fatigue, pain chest, and pain on the legs. Palpitations, history of family, blood pressure, cholesterol, and that is actually part of the clinical history, 6 cardinal signs. So the most important are breath short, coughing, wheezing, dizziness, edema, fatigue, pain chest, and pain on the legs. All right, so skincare. So this is something that is important to remember in nursing process, the skincare. Why? Because the patient who have heart failure, they are being in bed for long periods of time. And what happened? They are going to have some, first of all, the perfusion because the heart is not pumping as before. The tissues are not perfused as before. Plus the no mobility or no activity of the patient laying down in the same position, they are going to have some probably ulcers, formation of ulcers on the skin. So always need to check on that. All right, so the first line for heart failure drugs we talked already is the ACE, ARBs, and the beta blockers. We're talking about the digoxin that is used for first line treatments when the first line are not successful. So when the previous ACE, ARB, and beta blockers are not successful, we are going to use digoxin. So let's talk about like digoxin, and the main commercial is the lanoxin. So please, this is very important, very high yield. Digitals or lanoxin are going to be positive inotropic and negative chronotropic. So negative chronotropic, this digoxin can be used as antiarrhythmic. And positive inotropic, this is what we are using for heart failure. What they are going to do is to increase the strength of the heart. Okay, so just remember always, digoxin is going to decrease the heart because it's a negative chronotropic. Okay, negative chronotropic is going to decrease the heart rate. It's going to slow the heart rate. So you need to check the apical pulse. What is the apical pulse? It's in the 5th intercostal left side space of the chest. You're going to put the stethoscope and you're going to have 1 full minute checking 60 seconds, second by second, check the pulse of the patient. That is in order to detect more accurately if the pulse is less than 60. If the pulse is less than 60 beats per minute, you need to stop the medication. All right, so here we have the lanoxin are supplied in tablets of in micrograms. So what is important is about we are going to talk about the toxicity. All right, so the apical pulse, the therapeutic serum digoxin levels, and this is very high yield for NCLEX. That is 0.5 to 2 nanograms per milliliter or per cc. So that is the therapeutic serum therapeutic range in blood of digoxin. That is the 0.5 to 2 nanograms cc. So one of the things that we need to please remember is the brand bran is from plants in diet can diminish the absorption of digoxin. Okay, so here we have the let me see here just a moment. I have a problem here. Okay, so the digital toxicity. Digital toxicity, we have the cardiac pulse deficit, the difference between the heart rate and the pulmonary pulse. That means that you can people can have a fibrillation of the facial atrium. So put the stethoscope in the chest. Check. You have, for example, 100. Okay, and you have in the pulse. You have, for example, 70. So there is a deficit, a difference between the pulse in the chest and the arm. So that is a sign of atrial fibrillation. So that is mostly happening in patients who already had before a myocardial infarction, and they lead into fibrillation of the atrium, and that is how the thing is going to show. Digitals or digoxin or lanoxin toxicity is one of the side effects of signs of toxicity is seeing yellow or green halos around lights. That is a sign and symptom of digoxin. So what you should do in this case is do the antidote? No, you don't give the antidote at this moment because the antidote is being used for severe toxicities toxicity levels of digoxin. So the nurse, what they need to do is evaluate the client's digoxin levels as a lab test. Early signs and symptoms of digital toxicity include anorexia, nausea, vomiting, and bradycardia. Okay, so here's very interesting about talking about digitals. I will tell you the mechanism of action very short. Number one, digoxin is going to compete with so we have protein, sodium, potassium, ATPase, right? The sodium, potassium that is in the cell membrane. So the potassium, where is mostly located, is going to be located inside the cell, correct? And the sodium is mostly outside the cell. So the sodium enters into the cell, and the potassium is sorry, the sodium is coming in. So the sodium is coming out and the potassium is coming in. So that is the sodium potassium pump. So what happens is the digital is going to compete with the potassium. Is going to compete with the potassium. So the potassium is going to get in and the sodium is getting out. So if there is low levels of potassium, so there is place for digoxin get into the cell. So there are going to be toxic levels inside the cell. That is going to happen, for example, when you are using diuretics, Lasix. You're using Lasix, furosemide, and you are losing potassium. So you have hypokalemia. In this case, there is free area for the digoxin to attach to a receptor sodium potassium pump. So that's what it's going to do is that is going to increase the toxicity levels of digoxin. Okay. All right. So one thing here in addition is hypokalemia. I'm not going to ask about the AKG, decrease the T wave. I'm not going to do that because we didn't go through yet. But hypokalemia, when you have hypokalemia, the patient receiving digoxin, the patient is having risk for toxicity. Okay, the antidote. The antidote is going to be the digoxin immune F antibody is the Digoxin is not indicated for milder cases of digital toxicity. Okay, so when you have the digoxin toxicity, okay, so the digoxin is very have high affinity for the receptors. So the potassium that are trying to get inside of the cell are going to be totally blocked. So little by little, the digoxin is going to make the body have hyperkalemia. This hyperkalemia, so hypokalemia means high risk for uh, digoxin toxicity. Once you have the toxic levels, the digoxin that is attached to the sodium potassium, the potassium is totally cannot get into the cell. So the cell, outside the cell, in the serum, the potassium starts to increase little by little. So, and that is one indication for the digiban. If the potassium is more than 5 milliequivalents per liter, that is going to be called as severe digital intoxication. And that is how we are going to give the antidote. Then we have the natriuretic peptide. Natriuretic peptide is the nitrate, is a Natrecor, and this Natrecor, what it's doing is the opposite of aldosterone. Opposite of what is doing the aldosterone? Reabsorption of sodium and water. So what is doing the natriuretic peptide is the opposite, excretion of sodium and water. So the excretion of sodium and water. So who is producing that are the atriums of the heart, atriums of the heart. When the heart is distended, when too much water, too much fluid in the atriums, that said that there is too much fluid. So that is going to trigger out the release of the natriuretic peptide from the atriums and produce the elimination of water. Okay, so that is going to be used for heart failure. The phosphodiesterase inhibitors. The phosphodiesterase inhibitors are producing the vasodilation. That is the Primacor. This is high yield for the test. Vasodilation, decrease the preload and afterload, and is a positive chronotropic. Okay, the problem with this positive inotropic, that is going to lead into arrhythmias. Okay, this is phosphodiesterase inhibitor. Can you see the big name here? Used for end stage of heart failure. So any medications, patients are not responding to previous medication, you're going to give the phosphodiesterase inhibitors. We don't mix with furosemide because they can precipitate almost immediately. So here we have the first dose effect, the NSAIDs, this is a summary. Here we have the chronotropic and inotropic meds. Propanolol is negative, digoxin is chrononegative, ino positive. The Primacor is inotropic, so doesn't have chronotropic effect. Calcium channel blockers do not have chronotropic. Duvotamine, acetylcholine, just to know a comparison here, they are going to have the bottom channel calcium channel blockers is inotropic negative, for example. Here we have the magic tools. So please remember this value. Digital 0.5 to 2. Toxicity is always more than 2 when it's more than 2 nanograms per milliliter. And we are going to have another that is we already talked about, is commonly in NCLEX, is the theophylline. It's a methylxanthine that produce, remember, palpitations, right? And produce bronchodilation. So toxicity levels is 20 but micrograms per milliliter. All right, so that is about for the review today. So I will thank you everybody for attending, and hopefully that is going to be useful. Thank you so much.